after going through all these things, some of the things that the physicians have come up with is that we don't get a lot of like crash emergency kind of stuff around here, but we still need to be prepared for those kind of things. So we're all kind of taking turns doing talks about things that we might not see very often, but they're things that we potentially could see and would need to be able to recognize and know how to deal with. So there's going to be a quiz at the end, so pay attention. All right, so I'm going to just quickly cover these two topics. And when we're done, I hope that you know what they are and why they're important. Have a kind of working knowledge of why they happen, how they happen. Maybe be able to identify patients who could potentially have these problems, and identify the patients who do have these problems. And then just know what to do as the first one on the scene when they occur, because a lot of times that will be you guys. So first topic is umbilical cord prolapse. Really, really rare. I've seen it twice in 13 years. And so the definition is that the umbilical cord descends alongside or beyond the fetal presenting part. So when you think about cord prolapse, mostly people think about overt cord prolapse, which is where the cord is sticking out ahead of the presenting part, either into the vagina or even completely out of the vagina where you can see it. The other type that we think about less frequently is occult cord prolapse, where the cord is alongside the baby's head, but not past it. You might not even be able to see it. And sometimes you don't really know whether that's happening or not, but we know that it happens. Occult cord prolapse in particular can even occur with intact membranes, which is also something people don't think about. I'm trying to scare you. So this is emergent, obviously, because the blood flow through the umbilical cord vessels is compromised to some degree. So these are pictures of some of the different types. On the left is the one I was just talking about. So the cord is prolapsed. You can see it's being compressed between the baby's head and the side of the uterus. And it can cause the exact same fetal heart tracing changes as the two on the right. One with the complete prolapse outside, and then the other one where it's still complete prolapse, but it's not protruding down through the cervix or vagina. So we should suspect that this is happening when you see a sudden and prolonged fetal heart rate decel. Some risk factors for this: malpresentation, footling breech is the most common. Prematurity, low birth weight, so small baby, not as good of a plug to keep that cord from coming down. Multiples, which is, it's more common with the second twin, delivery of the second twin. Multiparous patients, so if you think about the way multips labor, a lot of times their station doesn't come down as soon as it does, or it may happen rapidly. The baby may stay high for a while, and so you're at risk for that. Ruptured membranes, obviously, whether that be physician caused or spontaneous. And then patients who have a lot of fluid, right? That head might be floating, or just, a big gush comes out and the cord just kind of comes out with it. So iatrogenic, that word means what did we do to make this happen? So obviously artificial rupture of membranes, application of a scalp clip or a IUPC. When we try to rotate the baby's head, sometimes you can cause this. Doing immunoinfusion has been known to be a risk factor for it. Version, and then it can happen during forceps or vacuum application. So we diagnose this when we see, like I said, a sudden prolonged decel, or moderate to severe variable decels, when up until just this spontaneous quick change you had a really normal tracing. And when you have that, you should always suspect this. So if you have a beautiful category 1 strip and then all of a sudden membrane ruptures occurs and you see these changes, this should be in the back of your mind. And it can occur, it doesn't matter whether they're 1 centimeter or 9 centimeters, but the average is about 5 centimeters. And then of course when you do a vag exam, you can feel the cord. The patient may also call you and say, hey, I feel something. Some conditions that can mimic this obviously are maternal hypotension, like think about epidural, abruption, uterine rupture, or vasa previa. Anything that's going to kind of rapidly cause a change in the baby's status. This is a typical tracing. Boom, boom, boom. Ugly. Okay, so first step, if it's you and you walk in to this and you kind of figure out that this is what's going on, call for help. So, other nurses, the OB doc, anesthesia, and pediatrics, which is, kind of our usual, round of things that we do. So then, the next thing while you're waiting for someone to get in there is go ahead and elevate that presenting part. Get your hand in there and push the baby's head up so that the cord is not compressed between the head and the cervix. With your other hand, put the bed in T-bird to get that gravity helping you. And then if the other option would be obviously to get the mother in knee chest position. We want to continuously monitor the heart rate, obviously, and then make preparations for emergency delivery. The other thing that they talk about doing is minimizing the manipulation of the cord, because when you let it hang out and get cold, it can cause the blood vessels to spasm and make the blood flow compromise even worse. So you want to just kind of cradle it and hold that head up and keep the cord at least inside the vagina if you can. So, yeah, you might be riding the bed to the OR. But, and this is the only picture I could find of people riding in a bed on the entire internet. I don't get that. But this did happen to me as a resident with about a 350-pound patient. So there was only room for me and one of her legs on the bed. But it worked, and she was 27 weeks, and I saw her 3 years later with a healthy baby. So the survival for this is actually pretty good, believe it or not. And how fast you get them to the OR is what counts. And so I can't emphasize enough the sense of urgency that has to happen when these instances occur. Most babies do fine, very little compromise, as long as you get that head up. But really it's just how quickly you move to the OR and get the baby out. So, alright, so on to the next rare topic. Wide range of reported incidents for this one. So, but still, either way you slice it, it's pretty rare. The definition of uterine inversion is that the uterine fundus collapses into the endometrial cavity, basically turning the uterus inside out, either partially, where it's just kind of a dip at the top, or completely, where it's like pulling the sock off inside out. It's an emergency because this can lead to severe maternal hemorrhage and shock, or even maternal death. And I've seen this a couple times too. It's not unheard of. This is a really gross picture, but this is what it is. That's what a uterus looks like inside out. So it's not something that you want to see. So we should be suspecting this when you're seeing mild to severe bleeding after the second stage of labor. Mild to severe lower abdominal pain, presence of a mass like what we just saw, either in the vagina or coming out of the cervix. Urinary retention is common because if you think about how things are lined up anatomically, it can kind of kink off the urethra basically by pulling the bladder down. And then one thing that you guys would probably notice before anybody else is that the fundus is not palpable in the abdomen. So some risk factors: big baby, right? Floppy uterus, rapid labor and delivery, short umbilical cord, use of something like tribunalin, Nullips, believe it or not. That's the one that always kind of shocks me because I would have thought, Multips would have a floppier uterus and it'd be more willing to turn inside out, but it's actually not. Presence of, some kind of uterine anomaly like a fibroid, retained placenta or placenta accreta, right? If it's really, really attached, it's not going to it's going to pull everything out with it. You notice in that list, it does not say anything about excessive traction on the umbilical cord, which we used to think that that's what caused it, like the doctor pulls it too hard. Well, the first thing is you really cannot pull hard enough for that to happen. The umbilical cord's going to rip off before you can do that. But they've studied it, And they actually measured the degree of force and all this stuff, and they found that there's actually no correlation at all between traction on the umbilical cord and uterine inversion. And that's what this slide's about, which I forgot this slide was next. So do we cause it? Not really. The other reason that we know that it doesn't have anything to do with traction is that spontaneous inversions occur, and it's rare, even though cord traction and fundal pressure are really common things to do. So if it was something that we were causing, you'd probably see it a lot more often. Okay. So the most common presentation is complete uterine inversion, where it completely turns inside out, and that's the only way I've ever actually seen it. And then you see severe hemorrhage, often followed by shock. And the interesting thing about this is that the degree of shock, like hypotension, can be out of proportion to the perceived amount of blood loss. So you may think, gosh, she really didn't lose that much blood. Why is she so hypotensive? It's because of the neurogenic shock component with this. What happens is when the uterus comes out like that, it causes stretching in the parasympathetic nerves. Am I getting too physiologic with you? So that stretching is what triggers the shock. It's not the blood loss. And so that's where you can see just a really rapid crumbling of the situation, because it's a neurologic problem. It's not a hemodynamics problem. Okay, so again, first step, call for help. Call another nurse, get the OB doc in there. I put anesthesia with a star because in this instance, even if you're able to resolve it in the room, you need to be able to quickly get to the operating room, because that's the only way you're going to get it back in sometimes. The next step is get another IV in there and just open up the fluids wide open. Discontinue Pitocin, because you want that uterus to get soft so that you can replace it. And make sure you've got your box with your TURB in the room, because most docs are that's the first thing they're gonna have you do is give them a shot of TURB. If the placenta is not removed, do not remove it. If you imagine that uterus turned inside out with the placenta attached, the placenta is really the only thing that's between us and massive hemorrhage. So if it's attached, you want to leave it that way as long as you can. And then of course replacing the uterus, and grab your hemorrhage protocol sheet, get it handy, and we all need to kind of be familiar with that and see where the next step is. Questions? And really no day is complete for me without a picture of Ryan Gosling. So anyway, I just thought these were cute.
Why does the Kevin Hart baby laugh so much?
Sorry?
Other drugs being given.
Other drugs being given. Okay, so the reason that I always say prepare to go to the OR, even if you get it back in, is because the best uterine relaxant is inhaled anesthetic. And so if I can't get it right back in, I'm going to the operating room and the patient's going to go to sleep. And then, that's how I've gotten them back in, usually with sevoflurane or one of those, or nitro, which I wouldn't give nitro in the delivery room. I would want them in the operating room to do that. So that's why just being prepared to get to the operating room really fast is important. It's not that you're going to do surgery. It's really, really rare to have to operatively replace the uterus. It's more because you might need to give them the gas to get it back in. So, yeah. You can't see them very good. Love that. Oprah. She's my favorite. Alright, other questions, guys? I blew through that. I mean, I assume you know a lot of it, but the point is just to kind of bring it back to mind, just to be prepared for these kind of things, because it's happening. I've seen them. I've seen uterine inversions for sure.
So once that uterus comes out and is exposed to the outside bacteria or whatever, do you do anything with it as far as keeping it moist or keeping it clean?
Well, there's no keeping it clean. I mean, it's come out through the vagina. So, I mean, usually I would put the patient on a course of antibiotics afterwards. But no, I mean, yeah, keep it moist, put a moist sponge or something on it, sure. But really, it's just, at that point, anything you can do to get it back in there. Yeah. So, I would assume that you guys would not be the one that's recognizing that particular problem because it usually happens right after the baby.
Mm-hmm.
But it can, most of them happen within 24 hours. It can happen 24 hours to 4 weeks after delivery. I've never seen that, but it can. So it's probably unusual that you guys would diagnose it. The key is really to just be aware of what the steps are going to be, once we see it. Other question? Okay. You guys want to do your little quiz and then go home?